I would like to introduce my thesis proposal with the title Effects of High-Intensity Inspiratory Muscle Training in Patients with Heart Failure with Mildly Reduced and Preserved Ejection Fraction, a randomized controlled trial. My presentation includes 6 parts. First of all, the rationale. Heart failure with mildly reduced and preserved ejection fraction who accounted for over 50% of overall heart failure and associated with high mortality. Inspiratory muscle weakness is one of the complications in heart failure. The prevalence of inspiratory muscle weakness in heart failure is very high, and this figure in heart failure with preserved ejection fraction is from 30 to 40%. Inspiratory muscle weakness is defined as maximal inspiratory pressure or MIP less than 70% of predicted value. To assess MIP, patients will be instructed to inhale forcefully at the residual volume to against an occluded airway of a digital device, like this picture, and the MIP will show in a number and present as a graph. Inspiratory muscle weakness makes exercise intolerance, dyspnea, poor functional capacity and quality of life. Inspiratory muscle training or IMT is an approach to strengthen inspiratory muscle. By that way, improve and reduce above symptoms. Until now, 2 trials were performed to evaluate the efficacy of IMT in heart failure with preserved ejection fraction. But most studies used low to moderate intensity IMT. In addition, they used unblinded trial design, small sample size, and lack of report of the compliance to home-based IMT program. An interesting finding is no previous study evaluated effects of IMT in heart failure with mildly reduced ejection fraction. So the gap of knowledge is that there have been no studies performed to evaluate the effects of and safety of high-intensity IMT on patients with heart failure with mildly reduced and preserved ejection fraction. Based on the current evidence, we propose 2 questions. Firstly, does the home-based high-intensity IMT program increase VO2 peak from baseline more than in sham controls in patients with heart failure with mildly reduced and preserved ejection fraction? And the second question is the home-based high-intensity IMT program safe? And does it improve MIP, 6-minute walking distance, quality of life, and echocardiographic diastolic barometers? The literature review. The treatment methods in heart failure include medical therapy, comprehensive care, and cardiac rehabilitation. And inspiratory muscle training or IMT is one of the components of the cardiac rehabilitation. The mechanism of inspiratory muscle weakness in heart failure comes from many factors, including respiratory muscle atrophy, change in muscle fiber types, muscle metabolic reflex, reduced oxidative capacity, ventilation inefficiency, and physical deconditioning. Additionally, there are some other factors affect inspiratory muscle weakness, such as aging, nutritional deficiency, obesity, medications, and comorbidities. Just like any other muscle, the respiratory muscle also need to exercise. Inspiratory muscle training is a type of resistance training which is proposed to enhance inspiratory muscle strength. And 3 components of IMT include intensity, frequency, and duration. The intensity depends on the percentage of maximal inspiratory pressure and divided to high intensity, moderate intensity, and low intensity. The mechanism of IMT in heart failure inspirator muscle training could improve inspirator muscle endurance, increase exertion capacity, alleviate metabolic reflex, enhance diaphragm thickness, change muscle fiber types, and improve ventilation inefficiency. By that way, IMT improve functional capacity. As I mentioned in previous section, there are two studies of IMT in heart failure with preserved ejection fraction, and both of them showed the significant improvement after intervention. There are also some studies of high-intensity IMT in heart failure were done, but both of them performed in heart failure with reduced ejection fraction. High-intensity IMT also showed efficacy in other populations, such as football players, COPD patients, and the follow-up time was often 8 weeks. So 8 weeks is enough time to show the efficacy of high-intensity IMT program. There are some common outcomes that related to IMT in heart failure. First of all, peak oxygen consumption or VO2 peak. It is the peak oxygen uptake during the exercise test, and it reflects exercise capacity. 6-minute walking distance and diastolic function based on the results of echocardiography. The quality of life. We will use SF-36 questionnaire to assess patients' quality of life. It is the conceptual framework. Heart failure with mildly reduced and preserved ejection fraction will present with inspirator muscle weakness, and IMT will have to increase the strength, speed of shortening, power output, and endurance of inspirator muscle. By that way, primary and secondary outcomes may be improved. So we conduct this study for two objectives. The primary objective to evaluate the effects of the 8-week home-based high-intensity IMT program on an increase in VO2 peak in patients with heart failure with mildly reduced and preserved ejection fraction compared to sham controls. And the secondary objectives to evaluate the safety and the effects of the 8 weeks home-based program of high-intensity IMT on improvement of maximal inspirator pressure, quality of life, 6-minute walking distance, and diastolic function. The research methodology. We use randomized controlled trial design. Patients with heart failure with mildly reduced and preserved ejection fraction in heart failure and heart outpatient clinic of King Chulalongkorn Memorial Hospital will be assessed for eligibility. They will be excluded if they meet exclusion criteria. Then they will be randomized to two groups, high-intensity IMT and sham IMT. The eligible criteria are as presented in the slide. The inclusion criteria: patient with diagnosis of heart failure with mildly reduced and preserved ejection fraction at age more than from 18 years old, and NYHA class 2 and 3. The exclusion criteria: gait problem, worsening heart failure, recent angina or open heart surgery, end-stage renal disease, post-heart transplantation, anemia, moderate to severe valvular disease, significant primary pulmonary disease, and comorbidity with life expectancy less than 1 year. And there are some withdrawal criteria. They're not interested with the study. hospitalization for other reasons, stop training for 6 days, new illness acquired during the training period affect the results. We use block randomization method with a block of 4 and 6 in a 1:1 ratio to 2 groups. Cardiologists, outcome measurement, and data analysis researchers are blinded to patients' location. Participants are blinded to another intervention. The intervention protocol. High-intensity IMT will be performed warm-up in 5 minutes. The training resistance will be set at 30% MIP in the first week, 50% MIP in the second week, and 70% MIP from the third week. The cooldown will be performed in 5 minutes. The sham IMT will be warm up and cool down similar to high-intensity IMT. The training resistance will be kept at 15% of MIP. The study endpoints. The primary endpoint is the change in VO2 peak at 8 weeks. The secondary endpoints include maximal inspiratory pressure, 6-minute walking distance, quality of life, and diastolic function, and experience of some adverse events. The compliance will be managed by a logbook, phone calls every week, and the checklist. This is the data collection timeline from the admission to the end of the intervention. The sample size calculation. We set the power at 80%, the alpha level at 0.05. We calculate power for VO2 peak using data from previous similar study. The results show that 12 participants per group is necessary to achieve the effect size Cohen's d of 1.256, and the sample size for 2 groups is 24 patients, assuming that 15% of patients will drop out of the study. The total participants is 29. The statistical analysis, intention to treat analysis will be considered. The normality of the data is examined by Shapiro-Wilk test. Independent t-tests or Wilcoxon rank-sum tests will be used, depends on the normality of data. Chi-square test or Fisher exact test will be used for categorical data, and the statistical significant level is p-value less than 0.05. The limitations. Some problems with compliance could arise, but we use phone calls and diary to alleviate the limitation. I intend to apply for the 19th anniversary of Chulalongkorn University scholarship to serve my study. The ethical issues. Cardiac rehabilitation is not implemented as a mandatory routine in the King Chulalongkorn Memorial Hospital. So comparing a high-intensity IMT program with sham control allows for a fair comparison to the usual care. And we also provide consent form and the opportunity to ask question anytime. Participants can withdraw from the research anytime. This is my study timeline, and I'm in the first stage. Thank you very much for your attention.